In this video, I'll explain why depression isn't one thing, and why the label depression can mislead treatment. Here's the common scenario. You take the antidepressant and nothing shifts. Or you do the therapy, fix your sleep, start exercising, cut alcohol, meditate, and you're still flat. Most people hear that and assume one of two things. Either you didn't try hard enough, or you're treatment resistant. But clinically, a lot of the time, it's simpler. We started with the wrong map. We treated the label, but missed the pattern underneath. I'm Dr. Sanil Rege, consultant, psychiatrist, and educator. I've treated thousands of patients with depression. And what I'm going to share today is my clinical experience and what really makes a difference to patients. By the end of this video, you'll be able to spot different depressions quickly and understand why one-size-fits-all approaches so often fail. Most people think depression equals sadness, but in the clinic, depression is often not about sadness at all. It can look like slowness, thinking and moving really slow, the patient feeling like they're dragging themselves through mud. 2, anhedonia, no pleasure, no spark, but not necessarily tears, brain fog, reduced cognitive bandwidth, not remembering what they had for breakfast or what they did yesterday, agitation, an internal motor that won't switch off, somatic distress, pain, appetite change, sleep disruption, constipation, nihilistic thinking, not traumatic, just a steady loss of meaning. Now, if we treat all of this as one thing, we'll keep having the same problem. The right treatment for one subtype becomes the wrong treatment for another. So here's the plan. In the next few minutes, I'll do 3 things. 1, I'll show you why depression is a bucket, not a single disease state. 2, I'll give you simple pattern spotting method that you can use really fast, clinically and personally. And 3, I'll walk you through 6 biological pillars that intersect, so you can see why one cause, one fix rarely holds. This isn't about making depression complicated. It's about respecting the complexity of depression. So let's start with the first reframe. Depression is a final common pathway. It's not a diagnosis in itself. You see, the DSM is useful. It creates reliability in diagnosis, but it can unknowingly destroy something else, meaning, because the word depression ends up doing 2 jobs. It describes a lived experience and it pretends it's a single entity. It's not. 2 people can both be depressed and have almost nothing in common. And this is important to recognize because we aren't treating labels, we're treating humans. One patient is tearful, reactive, sensitive to rejection. Another is numb, constipated, slowed, barely speaking, no emotional reactivity at all. Same label, but a completely different brain state, which means different treatment needs. So here is a quick way to understand depression. Depression isn't just about mood. It's a disorder of output. Think about it as the brain's ability to generate movement, initiative, cognition, reward, and future-directed behavior. Or in simple terms, to think is to move, and depression often disables both the thinking and the moving. So instead of only asking, are you sad? The better question is, what has fragmented? Sleep, thinking, energy, pleasure, threat sensitivity, or all of it, because those fragmentations hint at different depressions. And you might ask, why do different depressions exist? Why the heterogeneity? To understand this, let me take you to the 6 pillars briefly. These can be thought of as the etiological aspects that result in the final pathway of depression. And the important thing is, these are interlinked. Number 1, neurotransmitters, not chemical imbalance. Think of neurotransmitters as a gain control for networks. Dopamine for motivation, effort, reward learning. Norepinephrine, arousal, vigilance, attention, drive. Serotonin, flexibility, threat modulation, behavioral inhibition, impulse control, emotional regulation. Glutamate and GABA, noise versus stability in thinking. One is excitatory, the other inhibitory. So therefore, if there are different gain problems, there are obviously different phenotypes of depression. 2, structural and circuit correlates. Depression has been conceptualized as a network problem. 3 key networks: the prefrontal cortex, the executive control network, the default mode network, the creative mind-wandering part, and the salience network, or the limbic threat systems. These three are interconnected. So in some people, especially with metabolic or vascular risk, you can see disconnection effects, slowing of the executive control network, slow thinking, difficulty with attention, concentration, poor initiation of task, or in others, significant agitation with the salience network firing too much. Third, the HPA axis or the stress systems. We know that chronic stress can reshape arousal systems because cortisol is linked to noradrenergic systems. Some depressions occur with hyperarousal. Others present as shutdown, and those aren't treated the same way. Number 4, inflammation. For some patients, depression resembles a sickness state, fatigue, anhedonia, brain fog, pain sensitivity. And this happens because inflammatory signaling through cytokines can reduce reward responsiveness, resulting in anhedonia. But at the same time, it can increase threat bias by activating the amygdala. Number 5, the gut-brain axis. This is not the oversimplified prebiotics or probiotics and cure depression. This is more about understanding gut inflammation, microbiome metabolites, immune activation, vagal signaling. These are all interconnected and can influence drive, cognition, sleep. So therefore acts as an amplifying factor. Number 6, the phenomenon of neuroplasticity. Depression can be a plasticity problem, which means the brain becomes less able to update, learn safety, or generate new behavioral options. That's why the right psychotherapy at the right phase can be transformational, because it helps the brain revise prior predictions. This is not just about talking about feelings. So as I mentioned at the start, these pillars rarely occur alone. They intersect. That's why one depression doesn't exist, because think about the permutations and combinations. So let me make it real and visual for you. I'll give you 4 depressions. First, the shutdown depression. This is also known as the melancholic depression. Here, the patient doesn't necessarily say, "I'm sad." This presents as psychomotor slowing, both the thoughts and movement slowing down. But early morning awakening, loss of appetite, constipation, no reactivity to positive events, and sometimes nihilistic, hopeless, or hypochondriacal thinking, an overvalued belief of something not quite right in their body, or having an illness, or financial worries, obsessional guilt. These can drift towards psychotic features. 2, the wired depression, with agitation, mixed features, or heightened anxiety. This looks like racing thoughts, irritability, crowded thinking, insomnia, inner restlessness, the inability to relax, ruminations like a constant mental static where 1 or 2 thoughts consume the patient's life. In this case, what's being called depression can actually be a mixed state, mixed features, subthreshold bipolar disorder that's missed, or sustained hyperarousal. This is so commonly misdiagnosed as depression, and if an antidepressant is prescribed in this phenotype, it can result in significant agitation and can increase the risk of suicide. Number 3, the inflammatory-metabolic depression. This one presents with fatigue and brain fog. Fatigue and brain fog is often qualitatively different. There is a physical pressure. The brain feels completely muddled, not just slow thinking. It's associated with reduced drive and decreased reactivity to positive events as well. But it comes with pain sensitivity, autonomic nervous system dysregulation, and significant sleep disruption. Here, it's not just about medications. It's about broadening the lens to include inflammation, metabolic health, sleep, pain, and circadian health. Number 4, the depression shaped by trauma. This is where the nervous system in the brain is organized around threat. It may present with nightmares, hypervigilance or shutdown, dissociation, negative self-beliefs that feel like reality. Here, if we simply focus on medication, we might get a partial response. But the illness is maintained because the mechanism is prediction, safety, and meaning. So when we understand this, we now realize why treatment resistance is often a MAP failure. When we say treatment-resistant depression, we're often implying the patient is resistant or the illness is mysterious, but more commonly, it's simpler than that. We treated the label, not the subtype. So if we treat melancholic shutdown like simple sadness, we're missing the psychomotor and biological drivers. We're forgetting that melancholic depression requires noradrenergic and dopaminergic potentiation. So we need to match the appropriate treatment to the biological drivers. If we push antidepressants up in mixed features, we may destabilize mood and sleep and increase agitation. If we ignore sleep architecture, no matter how much medication we put in, the medications may lose effect, and we may label it as treatment resistant. If we ignore vascular, metabolic, and inflammatory loading, we keep wondering then why energy doesn't return. Well, these are the barriers: vascular, metabolic, inflammation. They prevent dopamine noradrenergic systems from acting effectively. So here's the effective shift. Instead of asking, do I have depression? Or for clinicians, does this patient have depression? Let's ask, what kind of depression is this? And what pillars are driving it? And even better, what started the initial fragmentation? Was it sleep? Was it cognition? Was it activity? Was it emotional headaches? Or was it threat? This moves us from label-only medicine to formulation-based psychiatry. And when the formulation improves, treatment becomes clearer. For clinicians wanting to think along these lines, we've got a 7.5-hour formulation and management masterclass in the Academy with case studies where I show you how to integrate multiple systems to create an effective management plan. So if there's one thing I'd like you to remember from this video, it's this: depression is real, but depression is not one thing. It's a family of syndromes with overlapping pillars requiring different maps, individualized to each patient. I'm Dr. Sanil Rege, and you're watching the Dr. Rege channel. If you found this video helpful, hit the like button and subscribe to our channel. Let me know in the comments section, what patterns did you notice when it came to depression, either within yourself or your loved ones? Because remember, treat the pattern, not the label. I look forward to seeing you in the next video. Until then, stay curious. Bye-bye.